And the last thing that's a little different is we've also switched our evaluations to being online only. Those of you who attended in person in the past will know that we passed out paper forms, which you would rate the speaker and the series on. That is all entirely online now. So we've got a survey link that we will show you near the beginning of the talk and again at the end of the talk. And if you go to the SPPH Grand Rounds website, the survey link will be there as well. So please do fill out that evaluation. And for those of you who need CME credit, that's how you will get that credit. You will fill in the survey, give us your name and your email, and that's how we'll keep track of things for the year so we can issue your CME credits. That is pretty much all I'll say, except for please do mark October 21st in your calendars. That is going to be our next rounds, and we are going to have a series of short talks about the real public health science behind zombies, because it'll be Halloween, it's 10 days from Halloween. It seemed like an appropriate topic. So we've got a bunch of cool speakers coming to tell you what, the real science behind everything from math modeling to diagnosing a zombie infection might actually look like. So with that, I will remind you that you can tweet questions. If you don't feel like asking one using the microphone, please feel free to tweet any questions during the talk to SPPH Rounds. Feel free also to use this hashtag to live tweet Dr. Morgan's talk. And so without further ado, I will bring up Steve. Steve Morgan, as you all know, he's a professor of health policy here in SPPH and founder of the incredible PharmaCare 2020 initiative, which is really about opening a national dialogue around universal pharmacare. As last year's winner of UBC's President's Award for Public Education through the Media, Steve is a superstar at communicating, and so you're in for a real treat to kick off this season.
Thank you.
Thank you, Steve.
And thanks to the organizers for the invitation to kick this new format for SPPH Rounds off. It's a real honor and a privilege, and I will do my best, hope not to disappoint. First of all, the administrative details, as Jen mentioned, concerning CME credits and filling out the evaluations, please pay attention to that. There are learning objectives required for all CME accredited courses or talks. Here are mine. Just briefly, what I hope by the end of this hour, you will have an understanding of essentially how unique Canada's universal health insurance program is, because it lacks coverage of prescription drugs. We are the only comparable health system in the world that does that. And I want to give you some evidence of the implications of that on the Canadian population and on the health system at large. And then thirdly, I want to talk about some work that's going to be published actually later this week, possibly, or not this week, sorry, next week or early next month, on the political influences as to why it is that Canada has what is actually a conspicuous hole in our universal health insurance system. In terms of conflict of interest, I actually have none to declare. I have no financial ties to any commercial interests in the pharmaceutical sector. I also, at this point, and for the last roughly 8 years of my career, have done no consulting for government on a paid basis. I do provide advice to governments at the federal, provincial, and international level, but all on a pro bono basis. I serve on World Health Organization advisory committees around pharmaceutical research and development, and on access to medicines, and on what is now referred to as the Fair Pricing Forum, a new initiative of the WHO to try to tackle issues around the high cost of medicines in health systems worldwide. So here we go, a better prescription. I want to talk about evidence and politics concerning pharmaceutical policy in Canada, and we'll mostly focus on universal pharmacare, or the lack thereof, in our healthcare system in Canada. The talk is broken up into essentially 3 components, hopefully of about 12 minutes each. We'll see if we can do that, and then we'll have plenty of time for questions at the end. I want to talk about history. I want to talk about theory and evidence concerning system performance, and I want to talk about politics. And any student of mine, and I see several students from my course and from past years, will know that we can have lots of evidence about policy processes, but we need to understand politics in order to know when and how that evidence is going to be put into action. So in terms of history, I like to start every talk I give about pharmaceutical policy in this country with this slide. It is a picture of the flag of the United Nations, and it is to remind us that the World Health Organization and the UN have made numerous declarations going back to the 1940s that say access to health care is a fundamental right, because health is a fundamental right. And by extension, the WHO repeatedly has stated that nations around the world are obligated to ensure access to affordable, appropriately prescribed medicines for all patients or all citizens of their countries. Consistent with that declaration and that obligation, every developed country with a universal healthcare system provides universal coverage of prescription drugs. Every such country except for Canada. We are conspicuous insofar as we don't have that. This was not planned. This was not really the intent of the Canadian National Health Insurance Program. Dating back to the 1940s, when federal and provincial governments were planning essentially what you could consider as post-war reconstruction for Canada, or at least the building of the welfare state that would become the Canadian welfare state, universal comprehensive health insurance in this country was envisioned, a comprehensive plan that would bring together medical care, hospital care, pharmaceutical care, home care, and dental care. The challenge in Canada, however, was that that wasn't just a matter of linking together those components of the health system, but it was linking together disparate provinces in a federation that actually assigns a tremendous amount of autonomy to provinces vis-a-vis the federal government. And in the 1940s, proposals by the federal government to have a largely federally funded universal health insurance program that would cover all of those components of healthcare, those proposals by the federal government were thwarted by the provinces, who opposed, most importantly, the notion that it might be federal, and secondly, some provinces opposed the idea that it might be comprehensive. So as a consequence, national health insurance in Canada, Medicare as we know it, actually developed in stages. Led, as many of you know, by Tommy Douglas in the province of Saskatchewan, models of universal health insurance in Canada began with hospital care. Douglas passed the first such model in 1947. The federal government nationalized standards for that kind of a universal public insurance for hospital care in 1957. Douglas then again actually created national or a new national standard essentially by passing in 1962 an act that would create universal medical insurance for all residents of Saskatchewan. And subsequently, the federal government, following the Royal Commission on Health Services, nationalized the standards for universal public insurance for medical services or physician services in 1966. The Royal Commission on Health Services of the time actually explicitly said that given that Canada was developing its universal health insurance model in stages, the next essential stages would include home care and pharmacare, and perhaps eventually dental care. We're still waiting in some sense. Canadian Medicare, therefore, is in some sense a valued and much cherished icon of our national identity. I think Canadians, for good reason, hold the principles of the Canada Health Act and of Canadian Medicare dear to their hearts. It is a differentiating characteristic for many Canadians vis-a-vis the United States, which doesn't yet have even the luxury of the kind of insurance that we have. But it is, in some sense, both a source of national pride, but it should, to some degree, and I hope I will convince you, as depressing as that may sound, that it should also be a source of national embarrassment, that our system of universal health insurance is so incomplete in terms of having a full spectrum of care provided for those with legitimate health needs. This isn't to say that we don't actually have pharmacare programs or programs that are public drug insurance programs of various names across the country. Every single province offers public insurance for vulnerable populations of one definition or another. Those definitions of vulnerable populations and the generosity, if you will, or the comprehensiveness of the insurance varies quite considerably across provinces. But for the most part, the Canadian models of pharmacare or of public insurance for prescription drugs target vulnerable populations such as low-income individuals for whom the cost of any medicines may be unaffordable, and persons over the age of 65. These models evolved in the 1970s, and in several provinces, including in British Columbia, they evolved as policies of the departments of welfare and social insurance, not the departments of health. They were essentially an income assistance program for people who were either very poor or very old. Today, the legacy of that model exists in many provinces. There are about 5 provinces that have an age-based entitlement to drug coverage, Ontario being one of them. And I'll talk a little bit more about the Ontario and other models in terms of evidence. But just to suffice to say, But these are models in which there may be some minimum safety net, referred to as a catastrophic drug benefit for all people regardless of age, like there is in Ontario. And then for people who are 65 years or older, there is essentially comprehensive drug coverage, subject to a reasonably modest deductible, depending on your income as a senior citizen in Ontario. Similar models exist in other provinces like Alberta, to some degree Saskatchewan, and Nova Scotia, New Brunswick, Newfoundland, and PEI. But there have been recent reforms in some provinces that have changed the complexion of public drug benefits. So, most notably, for instance, Quebec actually radically transformed their system of insurance to move away from an age entitlement to public subsidy for medicines, and actually move towards a compulsory private insurance model for insuring their citizens. This achieved the objective of universality, means all Quebecers actually do have insurance for prescription drug needs, but they do it through a mandatory participation in work-related benefits for health and pharmaceutical care. And as a consequence, if you are unable to obtain those sorts of private insurance through your occupation or your workplace, you then have to purchase a compulsory publicly run but insurance-looking drug plan, in the sense that it has annual premiums, it has annual deductibles, it has co-insurance rates, just like you'd expect of an insurance model for pharmaceuticals. And then lastly, since we're here in BC, it's worth mentioning that British Columbia also got rid of the age entitlement to public drug coverage back in 2003, or essentially phased it out over the course of a generation, by way of replacing that kind of model of pharmacare with a model that said, why don't we just provide everybody, regardless of age, with some level of catastrophic drug coverage. That is, coverage that requires you spend out of pocket or through voluntary private insurance, if you can access it, a certain proportion of your income before any public subsidies for medicines kick in. For the vast majority of British Columbians, that proportion is 3% of household income. And the model is essentially that no one should have to break the bank in order to pay their bills. And it is, again, premised on what we would consider a classic insurance model for drug coverage, in terms of just trying to protect people against the worst financial jeopardy, but not necessarily addressing other goals in the system. So I'll transition now to evidence and theory, at least, about what the performance of our system might look like vis-a-vis comparable health systems abroad with universal health insurance. I want to look at a number of comparable systems, essentially because Canada, we know there may be a problem, and I hope I can convince you of it, and we need to look for solutions and systems that might look a bit like ours, and that from which we might borrow some ideas. I've selected 9 comparable countries from a convenient sample in some sense. What I've used here is countries that participate in the Commonwealth Fund's annual International Health Policy Survey. For those that don't know, the Commonwealth Fund is a New York-based foundation that does a lot of work on the American health system, but is unique in the American sort of complement of research foundations because they have a specific mandate to look abroad for health system innovation and to see whether or not the Americans can learn from abroad. The international surveys that they do are much talked about in the press and certainly circulated in American policy, and they help countries like Canada even to do benchmarking. So I'm going to look at 9 of the countries that are in that suite. We're going to look at Norway, Sweden, New Zealand, United Kingdom, and Australia. These are all universal public health insurance systems or universal public health systems comparable to Canada's in the sense that it is truly government-financed healthcare in those countries. All of them have universal drug benefits in their systems. Australia's got a bit of a purple color here. I'll explain why in a moment. And then we're also going to compare, just for the sake of comparison, to social insurance systems in Europe. And so compulsory insurance by way of some form of social insurance mandate or a statutory insurance mandate exists in France, Germany, Netherlands, and Switzerland, all participants in the International Policy Survey, and all have some form of universal drug coverage. Now, I'm working right now with the Commonwealth Fund and with an international team of collaborators on a piece around the system designs that protect countries from high drug prices. And as it turns out, as we're working on this project, it strikes me as that this is a really good tool or thought experiment to think about system designs that also ensure access and affordability at the patient level. So this is actually work in progress, and I apologize, it's a very busy chart. But what I'm trying to do is classify the systems of pharmaceutical policy in a variety of countries. These are the countries that we're comparing to today, and in Canada, against a number of system characteristics that we think are functional in terms of ensuring access and affordability of medicines. So let me just try to describe this briefly, if I can, and I apologize that it's a busy chart. First of all, universal coverage. In terms of ensuring accessibility, we know that it is necessary that all persons be covered for the cost that they need, because all persons need to be encouraged to use medicines that may actually keep them healthy, well, and importantly, from public health system perspective, out of hospitals, which is a very expensive form of care. But ensuring access is not just about universality of coverage, it's also about making sure that patients don't face high direct costs of care. So that's going to be another component that's important to consider in terms of accessibility. And then moving on to thinking about affordability and price control and expenditure management, you have different kinds of designs of health systems, single payer versus multi-payer health systems. There's a lot of literature in the health economic literature writ large that says multi-payer systems are more expensive than single payer systems for a variety of reasons. Not the least of which is those multiple payers, the multiple insurers, as it were, have to compete with each other. They have to spend money on advertising. They have to engage in redundant and duplicative administration of the systems. Oftentimes they have to engage in actuarial science of trying to measure people's risks, and sometimes engage in some forms of subtle and not so subtle ways of cream skimming, of making sure that their insurance pool only applies or only appeals to the healthiest of the population. So there are various administrative reasons why single payer systems are more efficient, but there are also, in a pharmaceutical sector, reasons that you might say single payer systems are more efficient, and that relates to the unique market power of the sellers of pharmaceuticals. Pharmaceutical manufacturers have a variety of government conferred forms of market power. Intellectual property by way of patent law. They have market power by way of data exclusivity of the trial information submitted to national regulators. And they also have market power even by way of the natural barriers to entering a pharmaceutical market. If you and I wanted to start a pharmaceutical company, we would have to spend an enormous amount in the sunk cost of infrastructure, machinery, manufacturing, and in the licensing and regulation of each individual product we would bring to a market. So in essence, this is an industry that's made for big players, particularly within therapeutic marketplaces. So within the marketplace for diabetes treatments or ulcer treatments or antibiotics even, there are higher degrees of concentration in the pharmaceutical marketplace than you would think of if you just looked at the market writ large. Yes, there are literally hundreds of manufacturers of medicines around the world in the entire marketplace, but for each therapeutic subsector, the markets are typically dominated by a small number of firms. It's a bit like a grocery store. Yes, literally thousands of manufacturers or distributors produce the things that you buy in a grocery, but when you go down the breakfast aisle and you look at the cereals, you're probably looking at only one or two manufacturers. So given the unique nature of market power for instance, pharmaceutical manufacturers, there is some advantage to having countervailing market power of a single payer, of having a negotiator that says it's either yes or no to coverage in a health system. And that countervailing market power on the demand side can, and in fact does, as evidence will show, demonstrate or manifest itself in significant control on prices and expenditures. But in order to make that countervailing market power efficient and evidence-based, you need two more ingredients for a high-functioning system. You need a national formulary. You need some list of medicines that are the medicines that are approved for reimbursement in your system. And more importantly, you need robust, clinically defensible and ethically defensible and arguably economically defensible systems for determining which drugs get on that list for which patients under which conditions. And systems around the world actually have developed such systems indeed. And then lastly, for health system efficiency, in terms of the incentives for both managers of a health system, but also the health professionals that work within it, we need some level, or we think that some level of integrated financing will facilitate a degree of cost consciousness. Awareness that, in fact, use of medicines when appropriate saves money elsewhere in the health system. Therefore, the investment in medicines is often in a good investment in health. But also awareness that sometimes medicines that are priced above a reasonable limit in terms of value for money from a public health system perspective or from a statutory health system perspective as per Europe, sometimes you need to say no, because investment in those medicines may be crowding out other potentially better investments in the health of the patients that are served by the health system. So having gone through those characteristics, we can kind of see fairly quickly, and I've ranked, this is my own view of these systems, I've ranked these systems according to the characteristics, green being they've got it, red means they don't, and yellow means, you could argue that they do or don't, and we could have a debate maybe after the seminar about some of these characteristics. What you'll see here is that on theory alone, you might predict that New Zealand, the United Kingdom, Norway, and Sweden might do fairly well according to these system design characteristics. They're all more or less in place in all of those systems. Australia I had in purple because, interestingly enough, it has a universal insurance system for medicines in Australia. But like Canada, it did so in a federation, that it has devolved responsibility or differential responsibility for health by way of the Commonwealth and state government. So there's a level of disintegration, or a level in which it's not actually integrated with the financing of the rest of the health system. But also, Australia has a uniquely high level of co-payments for patients filling prescriptions. It's $38 per prescription in the Australian context. Now, to many Canadians who are covered under public programs, you'd think $38 is nothing by Canadian standards, because oftentimes Canadians face much more per prescription. But by international standards, $38 is literally an order of magnitude higher than most systems charge. Most of the other systems charge nothing, as per in England, Wales, and Northern Ireland for prescriptions, or very little, often less than $5 Canadian for prescriptions in other systems like New Zealand and France and Germany. France has a bit of a yellow mark here because they have this complicated system of co-insurance, but about 85% of the French population buy private insurance to pay for their co-insurance. So essentially no one pays for anything for medicines in France. You can see then that the social insurance systems that we might borrow ideas from in Europe also has some issues in terms of they don't necessarily have an effective single payer because they have multiple competing insurers in their markets. And they don't necessarily have a national formulary because depending on the different competing insurers, they may or may not actually be controlled or required to fund the same medicines. And then lastly, below the line, it's kind of sad and kind of dismal. And to be honest, Canadian policymakers often say that I'm out to make them look bad, which is sad. I can tell you I've worked for the last 20 years with people who manage provincial and territorial drug plans in Canada, and I know that every single one of them is doing the best they possibly can to run the systems that they have as best as they can. The problem is their systems are fundamentally flawed. The structure of their systems, not their performance as managers of it, but the structures of their systems fail these tests in terms of the, at least theory, concerning what would be the system you would design to achieve desirable outcomes. So let's see the evidence. Let's see, how do we perform on key measures? These are measures borrowed from a variety of frameworks, including frameworks that I have written over the last 10 years about how to measure performance of pharmaceutical policy. But it's based largely on the World Health Organization declarations and World Health Organization guidelines for national medicines policies that have existed for 30 or more years and have been updated fairly regularly. So we're going to look at access, we're going to look at quality or appropriateness, we're going to look at fairness and value in terms of the affordability of medicines to individual households and to the health system as a whole. So access to medicines, number one goal of policy in this area. Indeed, it's a right of citizens to have access to the medicines they need for the conditions that affect them. Here's how we perform. This is the percentage of adults over the age of 55 reporting financial barriers to medicines as per the 2014 Commonwealth Fund survey. So this is reasonably recent data. And it's actually an MHA student, Augustine Lee, and I have done a couple of papers using this data, and hopefully they'll be published soon. But I'm giving you the sneak peek at the results of this analysis. In Canada, interestingly enough, there are no more significant differences for these older adult populations in terms of the use of the medicines. We see relatively comparable cost-related barriers to medicines in Canada. But as you can see, vis-a-vis international comparisons, we are much higher. In fact, amongst most of these countries, the New Zealand, United Kingdom, Norway, Sweden, skip Australia, Netherlands, France, Germany, and Switzerland, amongst all 8 of those countries, there's no statistically significant differences in access barriers. However, Australia and Canada are statistically significantly higher on this chart in these data in terms of access barriers to medicines. And no surprise, Australia has these very high co-payments per prescription, and Canada has a lack of complete coverage. There's about 20% of Canadians are deemed to be either uninsured entirely for medicines or underinsured, in the sense that they have to face a significant proportion of drug costs out of pocket, either before coverage kicks in or while coverage is already kicking in by way of having to pay co-insurance or co-payments. So we fare poorly on this regard, and I want to be clear that access matters. There is a powerful, perhaps understated paper about diabetes treatments in Ontario that was published a few years ago by Gillian Booth and colleagues from the University of Toronto. They looked at socioeconomic disparities in diabetes mortality and morbidity in Ontario for people above age 65 and people below age 65. And you'd think, well, why would you look at that? Well, the reason was simple. Above age 65, residents of Ontario have essentially comprehensive drug coverage. Below age 65, they don't. And they found that socioeconomic differences above and below age 65 were statistically significantly different. That is, that the disparities across income groups under the age of 65 were greater than the disparities across income groups over 65. And as a consequence, they found out per year of follow-up, just over 800 Ontario residents died prematurely. 800 Ontario residents in the younger and middle ages, under age 65, died prematurely each year during the study because of these socioeconomic disparities. Disparities that they attributed in part, possibly even in large part, to disparities in access to the treatments that they need. I want you to think about that. That is like a plane crashing every year, a plane full of Canadians crashing every year, possibly every month, while governments think about whether or not we have an access problem to medicines in this country. Now, even if you only attribute a portion of that difference, of that 800 persons per year, we have a true public health issue in terms of access to essential medicines. And then very few people would argue that, for instance, the treatments used to manage diabetes, certainly the tried and true effective treatments, are anything but essential. So moving along, what about quality, safety, and appropriateness in terms of the system performance? Well, this is an area which I beg anyone to take up as a work of their lifetime. We have very poor data to compare health systems on quality use of medicines. In fact, countries, I think, are doing a poor job, including Canada, in terms of the routine reporting on whether or not our patients are using medicines when and how they're supposed to be used. So I'm going to use proxy data about the quality use of medicines at first glance, and that is the percentage of the practicing doctors in this health system that report using an electronic health record on a regular basis. And Charlene Black is laughing, going, I think she's thinking that Canadians, they're not using EHRs at that rate. And I think that people at InfoWay Canada probably would agree. We're probably overstating even in Canada this, but nevertheless, one of the things to point out here is that all of the universal public systems, particularly those with integrated financing, so not Australia, all of those public systems with integrated financing, they invest in health information because it's a closed loop, it's a closed budget. It's essentially, integrated financing means integrated care. You make sure you're tracking appropriate use, you make sure you're tracking patient outcomes, and in fact, in many cases in these systems, the practitioners are getting real-time point-of-care clinical decision support using electronic prescribing tools. And that's the kind of investment that Canada ought to be making. We aren't right now because we have this highly fragmented system of healthcare delivery in the country. And in some sense, I think, to be honest, because pharmaceuticals have been outside of Medicare, it's always been perceived that the use of medicines is somebody else's problem. It's outside of the core concerns of Canadian Medicare, and therefore outside the core discourse around health policy in this country. And just suffice to say that some of the other countries, most notably Switzerland, perform fairly poorly on this level. And again, theory might predict that, well, a highly fragmented, highly competitive, almost free market system like Switzerland might actually have a similar disincentive for investment in total comprehensive care, including collection of data and reporting, because it's not necessarily the first and foremost consideration of those running the insurance plans. And in the Canadian context, earlier this year, actually, colleagues of mine and I published a paper showing that for seniors alone in Canada, we spend over $400 million on potentially inappropriate prescriptions for senior citizens across the country. And that's for the prescriptions alone. If you look at the rates of inappropriate prescribing to Canadian seniors, which is approximately 1 in 3 seniors receiving at least one prescription that is from a list of medicines known to pose greater harm than risk for older patients. If you look at the potential downstream costs of those inappropriate prescriptions, the total cost in Canada for inappropriate prescribing to seniors alone is estimated to be nearly $2 billion a year. Never mind the implications in terms of the quality of life or length of life of those for whom these prescriptions are being written. And I'll stop here just to say that when we are talking about developing a system of universal pharmacare, hopefully one that's integrated with the rest of the health system, we're not talking about an open bar for pharmaceuticals. We're talking about a system of ensuring that we have access to appropriately prescribed medicines for all Canadians at a cost that is affordable to them and to society as a whole. So let's talk about the cost and affordability issues. Fairness and equity is one of the considerations in health systems in terms of how much of the burden of health system costs rests with the patients or the patients' families themselves. There's a lot of literature on health economics that looks at equity in financing health systems, and it basically focuses on the idea that the needs for care should not exacerbate prevailing income inequality in a society. We know there's inequality in society, and maybe even health system financing could make that inequality a little bit less, make it a little bit more egalitarian. But what we wouldn't want to do is see a system designed in a way that made prevailing inequality and economic opportunity in a country worse because of health needs of the families affected by illness. So in some sense, the optimum design for fairness is to protect patients from direct costs of the care that they need. This is a slide that we don't have recent data from the Commonwealth Fund survey. I've got to work with the folks there to see if we can get some questions back into the survey. It's been 9 years since they've specifically analyzed data on pharmaceutical costs. So we have to go back to 2007 with a smaller number of participating countries to look at out-of-pocket costs for prescriptions in a given year from that survey. And then for the gray bars here in Canada, we used the Survey of Household Spending, an analysis that we did a few years ago on that, to show that actually Canadians face varied out-of-pocket costs by province. Interestingly enough, Ontario fares fairly well in this regard. And the Ontario government actually likes to celebrate that if you look on their website, and particularly as they talk about their seniors' drug benefit. Seniors are very well protected in Ontario. Less so in British Columbia because of the deductibles under our system. And in Quebec, even though they have universal access or universal coverage through a mandatory insurance model, that model has deductibles, co-payments, and whatnot, and co-insurance that add up. And the caps on those costs out of pocket are not per household, they are per adult in a family. So if you are a 2-person senior couple, you can expect, in the Quebec example, to face fairly considerable out-of-pocket costs for pharmaceuticals. And the key thing here, in comparison to other countries, only Australia looks like us. And again, that's probably attributable to the fact that Australia has that system where they have very high costs per prescription filled. And the difference in these other countries is not statistically significant, but the difference between us and them is. And Angus Reid Institute last year did a survey, and I was involved with them with the support of the Mindset Social Innovation Foundation here in British Columbia to do a national survey about affordability and accessibility of medicines. And they found a lot of stuff that sort of supports and reinforces some of the findings I'm showing today. But one of the stats is that they found that nearly half of Canadians are worried about their ability to pay for their pharmaceutical needs in the future. And what's interesting about this survey is that straddles all age groups. It's actually those of us in our middle age group that are most worried about our affordability of medicines in the future. And it also straddles all income groups. A significant proportion, 1 in 3, of Canadians who earn over $100,000 a year report that they are worried about whether they can afford their medicines in the next 10 years. You would not see this in any comparable country. This would not show up as something that is on people's minds as a worry in their hearts. So this is quite concerning. Lastly, value and sustainability, then we'll get on to politics. Value and sustainability, the affordability of medicines for the health system writ large. This chart is those countries color-coded with the blues and the pinks and the purple to give you an idea of how health systems differ. And then I broke Quebec out of this because Quebec is a universal mandatory private insurance market. And as you can see, it's the most expensive way to achieve universal coverage of medicines amongst every comparable country you could find. In fact, if you put the entire OECD database into this and said, of the countries that have universal drug coverage, and that means you take out the rest of Canada because it doesn't have it, but Quebec does. Quebec would be well above every single country on that mark. The rest of Canada spends a little bit less, partly because of more aggressive stances towards cost control, and partly because the multi-payer system of Quebec's model, that is mandatory insurance through essentially private insurance markets, it doesn't care whether costs go up. In fact, the insurers get paid a percentage of the amount of claims that go through their system. They almost have the opposite incentive to cost control. The incentive in that market is to let the costs go up because the insurers make a portion of what claims they process. If you don't think that those differences are significant, just have a look at this. If Canada had a system that was like New Zealand's and we spent on pharmaceuticals at the rate that they do in New Zealand, for prescription-only medicines alone, we would be saving over $18 billion a year. That's 18 billion with a B. You could buy every single NHL hockey team that is playing hockey in the United States at fair market value and build a $500 million stadium for them to play hockey in Canada with $18 billion a year. This is real money. And never mind the fact that you could double the amount of primary care workers that are working in the Canadian healthcare system, increase the nursing workforce by 50% with that kind of money. Even other comparables that we would probably more likely look to as we could probably reach their standards, whether that UK, Norway, Sweden, they're all in the ballpark of around $10 to $12 billion a year in savings vis-a-vis Canada's. And work that we did and published last year in 2015 in the Canadian Medical Association journal substantiates that claim with real, valid simulations looking at actual utilization of medicines in Canada and actual prices of medicines in Canada. Canadians really and truly could save billions of dollars if we, in a system that had universal coverage, but also therefore the purchasing power of single-payer systems like you see in the single-payer systems here on the chart in Scandinavia and the United Kingdom. So, to sum up the evidence and get quickly onto the politics, Canada's system provides less access to medicines, less safety and appropriateness, less value for money for the health system, and less financial equity than comparable systems worldwide. Ultimately, our system is failing, and theory would predict this. This is not a surprise. We've known this for a long time. So the question is, why haven't we done it? This answer has been staring at us in the face for 60 years. In the 1940s, during the wartime, post-war Reconstruction negotiations, drug coverage was part of the model that Canada was to strive for. In the 1960s, the Royal Commission on Health Services said that Canada should have a universal public system for drug coverage for all the reasons I've basically described today. This is old news. I'm not much of a scientist in some sense because I'm repeating or rediscovering things that people have known for a very long time. It was repeated again in the National Forum on Health in 1997, again by Romano in 2002. We haven't got there. Well, why? I'm going to talk a little bit about a paper that Catherine Booth and I have coming out shortly in the Healthcare Management Forum, a Canadian Health Leaders Journal, about the political influences on pharmacare in Canada. And we're using the 3I framework. You can think of it as 3 I's, lenses with which you might look at political issues, or the 3 I's, meaning interests, institutions, and ideas, and how all 3 of those things affect political incentives. So institutions, Canada is a federation. And at various times where Canada might have passed pharmacare-like legislation in the past, when royal commissions came down in 1965, when the National Forum on Health in 1997 and when Romano came down in 2002. You can see here I've kind of color-coded the political spectrum. This is the federal government, and on all the provincial premiers are all the provincial governments. And you can see that when these commissions came down, we had liberal governments each time. But we had conservative governments in Ontario and separatist governments of one form or another in Quebec. Game over. You will not pass a major national initiative like pharmacare when the two largest provinces, representing the two largest voting blocs, even in a federal election, are of a different political stripe. And similarly, if you look across the spectrum in all those eras, we had various things within the provinces that create federal-provincial tensions, making it difficult to pass legislation on this front. Today is quite different. Today is, in some sense, a window of political opportunity. Look at Alberta. That will not likely happen again in many of our lifetimes. Seize the day, carpe diem, right? Ontario and Quebec are currently liberal or liberal-affiliated governments, and they have a prospect of cooperating. We have a bit of a problem in British Columbia. That there's evidence to suggest that BC's not quite willing to cooperate on, for instance, the health accord negotiations, focused more on money than they are on system design and accountability. And similarly, in other conservative provinces like like Saskatchewan and Manitoba, we have a bit of resistance. And even from Quebec, understandably, given the sentiment of Quebec of health system is theirs to control, there is politics behind the decision-making there that is making it a bit difficult to move forward. But this is as good as it's going to get in Canadian political history, or at least over the course of our lifetimes. What about interests? Well, one of the interests that's important is the fact that those of us in this room, particularly those of us who are on faculty, and many of you listening on the phone who happen to work for larger corporations or even in private practice but buy insurance through your medical association, you have, through your employment, some level of drug coverage. You don't really care. You probably don't know how much of your premiums go into funding the medicines component, the pharmaceutical component of your health insurance. So this, in some sense, is not a big deal to you. It's a bit like climate change. You don't really feel it, but it's happening. Billions of dollars are being spent, perhaps unnecessarily. Millions of Canadians are not getting the drugs they need. And literally hundreds, if not thousands of Canadians are dying prematurely as a result. But for most of us in the room, and for most of the political elite, those working for large corporations, those with significant incomes, myself included, this is not an issue. So the framing effect of private insurance has been one of actually maintaining a status quo because the median voter in this country and the political elite, we don't feel the issue. The issue is felt most greatly by those with the least power and most vulnerability. Another interest, while we're at it, has to be, it's the elephant in the room, is the financial conflict of interest of the players in this industry. Bob Evans has this line that he had repeated again and again and again over his incredible career as a health economist. The best line that he ever repeated over and over again. And there are many good ones. But that is that every dollar of expenditure in a healthcare system is a dollar of somebody's income. And if I say we can save somewhere between $3 billion and $7 billion, or between $7 billion and $10 billion through a universal pharmacare system, that means that there are between $3 billion and $7 billion, or maybe $7 to $10 billion worth of opposition to that reform. Because that savings is currently somebody's income. Whether it's the retail pharmacies that are distributing medicines that are higher priced than they need to be, and many times receiving somewhat secretive paybacks from the manufacturers of generic drugs, for instance, under the current pricing and reimbursement scheme. Or whether that's the manufacturers of the medicines themselves that would have to compete more aggressively, would have to price more fairly in Canada, or at least have to provide the ever prominent these days discounts on medicines, not just to government purchases, but to all purchases, because government would essentially cover all Canadians. And also, and not to be left out, the insurance companies. If we had a system like every other universal public health system, we would have virtually no role for private insurance for medicines. Maybe complementary insurance to cover the drugs that were left off the public formulary, but not much at all. And that's billions of dollars in revenue loss to the insurance industry. And lastly, and I'm sorry for going a little bit long, but this is the last, I think, ideas matter. And I thank Catherine Booth for pointing this out to me. She was a graduate student of mine in political science, did her PhD. Now she's a prof at McMaster. But I learned more from her, I'm sure, than she did from me. And this is the idea of the political elite. Not like just you and I, not just ideas about the issue writ large in society, but the ideas of people around a cabinet table. Your members of cabinet at the federal and provincial level, they matter immensely in terms of shaping policy. And Catherine has a great book on pharmaceutical policy in Canada, Australia, and Australia and the United Kingdom, articulating that, in fact, if you look at cabinet briefings that have now been released to the public from the 1970s, it was pretty clear that the political elite just didn't think this was an issue. And key political figures in the room didn't think it was an issue. So in some sense, the ideas held by members of Trudeau's cabinet, frankly, matter immensely. And whether they think that the potentially hundreds, if not thousands, of Canadians that are dying prematurely is a problem, whether they think the billions of dollars being spent unnecessarily is a problem, whether they think the burden on families, unions, and employers is a problem, that is what matters. And to some degree, to close this up, that's one of the reasons why we launched Pharmacare 2020 a few years ago. We were trying to let the public know about the nature of science in this field. It's not new science, but it's new to a lot of people, and probably to a lot of you. And eventually, at the very end, if enough people are aware enough and mobilized enough, then those around the cabinet table will realize that even if in their minds this is not that great of a problem, in the minds of those that elect them and give them the right to be around that cabinet table, it is. And with that kind of understanding, awareness, and mobilization, we might just get there. So I conclude this talk, as I do with many, every universal healthcare system every developed country with a universal healthcare system provides universal coverage of prescription drugs, and so can Canada. Every comparable country proves that it can be done, it can save lives, and as a bonus, it could save billions of dollars. Thank you.
Myself back up here. So as a reminder, those of you in the room could just ask questions live, and I'll drop my microphone again. Mic drop, and then I'm out. There we go. And those of you who are tuning in online, can ask questions on Twitter with the hashtag SPPH rounds. I'm going to start with one of the questions that came in online. It's a long one. It took 3 tweets to hold. What are the relative merits of reducing cost barriers by including drugs in the health plan alone versus single-payer purchasing to constrain prices, but also add ensuring a living wage as part of the social policy change? You discussed seniors, but what about middle-aged folks facing this stagnant wages too?
Yeah, so this is an interesting question because it is a classic in debating contemporary policy issues. What I've said about pharmacare matters, and it matters in terms of the determinants of health of individuals, therefore the population, and it matters in terms of the efficiency of our health system. But anyone who focuses on health care policy per se knows that health care policy is only going to address the end of the spectrum or the distribution of health status in our population. If you want to shift the distribution, you go after the non-medical determinants of health. You will never find me opposing things like a living wage and greater equality in our society. So yes, there are bigger levers to move the health of the population than worrying about prescription drugs. But as it relates to the performance of health care in Canada, there is no bigger lever. I think there is nothing that is feasible for Canada to do right now that will have a greater impact on the health and well-being of Canadians.
Questions from in the room? We'll go to the back first.
Yeah. Thanks, Steve. Great talk. One thing that you presented on, but I'm not sure you said, but I think it's really important for students to hear, is that more money doesn't buy better healthcare, better health. I think you presented that on one of the graphs, but you didn't actually say that. So I think there's still a misconception out there in the public on that. But my question is, on the interest point, and I love the 3I framework, I've used it in the priority setting realm as well. If you take the first interest point that you discussed, and you think through why so many people in middle or high income aren't as interested in this policy issue. If you incorporate the private insurance that many people in middle or high income hold, where would we stand, internationally speaking, on that chart that you had where all the Canada provinces are basically and New Zealand was green. If we incorporated that alongside of the publicly funded insurance that we do have, where would Canada rise to?
Yeah, so the question, just for those listening online, is if you look at the availability of private insurance in Canada, and how does that affect how we would rank Canada in terms of the institutional features that might predict performance? And to some degree, given that about 2/3 of workers have some form of extended health insurance for their families, it does raise us closer to universal coverage. But again, approximately 20% of Canadians are either uninsured, that's about 11% or 10 or 11%, or underinsured for medicines. That is, they pay most of their drug costs out of pocket because they haven't hit deductibles or because of coinsurance. So we still don't quite get to the green status. Again, Quebec is green on that front because of mandatory participation in the insurance plans. But writ large, it doesn't quite get us as far as we need to. And again, just to repeat the comment that was made before the question about the fact that it's important that the audience, both in the room and online, realize that more is not always better in health systems. More spending is not always better in health systems. I think a lot of us in health policy and SPPH would agree that, in fact, a renewed health accord should not be checkbook federalism. It should not just be more money for the status quo. What we actually want is money to affect substantial change that might actually create a higher performing system. And that doesn't necessarily require a lot more money. It does require a bit for incentive purposes to get the provinces to play. But the point that Craig Minton made was very well taken. More money is not always the answer. And this is an example. Pharmacare is a situation where, yes, more federal money or more money from the government, but a lot less money from the private sector going into it. So in total, again, we would actually be buying more with a lot less money.
But two questions from online here. One is a 5-tweet question, so I'll just ask them both at the same time. So the 5-tweet question is, thanks for your excellent talk. I work in global health. Correct me if I'm wrong, but if the expansion of health insurance schemes in sub-Saharan African countries follows the development of schemes in OECD countries, the addition of drug coverage will be late in the evolution of the schemes. I suspect the timing of this inclusion matters to population health and costs, but decision makers are making trade-offs between including drug coverage and expanding the schemes in other ways. Which countries, here's the question, the long lead up and then the big moment, which countries provide strong examples of early inclusion of basic drug coverage?
Yeah, so that's a great question, and particularly when you're talking about lower and middle income countries, I defer to experts that focus on them. For better or worse, I've focused my career in pharmaceutical policy on middle and higher income countries. But there are examples. Most of the developed countries that actually have universal health systems that we talked about today develop their drug coverage very early on. In fact, in Australia, the one kind of outlier amongst public systems, they develop their drug coverage first. Then they develop their coverage of medical insurance later on. But there are a variety of countries. I can't pick one offhand as a great exemplar, and I'm happy to chat on Twitter with whoever that might have been.
Right. And the other Twitter question we had was, how do you sustain the media's interest in this topic?
That's a great question. I don't know. I've tapped out. We continue to do science. I think that's the strategy, I think, of anyone in this school. I've got some really amazing papers coming out in the next 12 months, hopefully the next 4 months. Editors, if you're listening. And I think they're going to get the attention of Canadians again, because the science is behind reform here. And media have picked up, thankfully. And I have great relationships with a whole host of journalists, and I know you do, and I know a number of people in our school do. Who really care, and they're eager to get that science when we produce it. So we'll work on that. Whether the big labor movements and the big labor groups take this up, that'll be another way of keeping this in the agenda. And the other group, and I apologize for going long on this one, employers. So in British Columbia, you probably aren't aware of this, the BC Chamber of Commerce endorsed universal public pharmacare, and they explicitly rejected the Quebec option at their last annual general meeting this summer. And they did so with the leadership of the Surrey Chamber of Commerce, or the Surrey Board of Trade, whose leadership said, wait a second, for our members, the employers of Canada, they're getting essentially screwed on high costs and barriers to being able to provide for their employees and their employees' families minimum coverage. And if they do provide it, there are these inefficiencies that they would far rather be managed essentially by the public system. And they make the argument, and it's an interesting one, and I think if this comes up in the media and in the debate in the next year, it'll be interesting. They're making the argument that employers and unions could sit down and talk about the savings from a public pharmacare system and how they would reinvest that, how they might expand coverage for mental health services, uninsured mental health services, which Canadians desperately need. So that would be another narrative that might help keep this issue alive.
A good follow-on question from that, actually, that is online here via Twitter is, what can the average Canadian, what can we do to drive change?
I wish I knew the answer to that. I mean, write letters is one thing you can do. Share your insights and information. Visit pharmacare2020.ca, which is our website for our evidence-based report on what we call the future of drug coverage in Canada, which is endorsed by nearly 300 professors across the country. And if you're a professor listening to this in this room or across the country, write me an email and add your name to the endorsement if you'd like. Read the report, of course, and see if you agree. But you can get engaged in a variety of ways. I wish I knew the magic way. I think we've got to go to Dave. He's had his hand up for quite some time.
So Steve, thanks very much. You've been talking about the affordability of a suite of medicines, and I want to ask about availability of a suite of medicines within the marketplace. Have there been any examples where a single-payer integrated system has actually been able to incentivize the introduction of otherwise orphan drugs like new antibiotics by making small concessions in other ways to the commercial players in the marketplace?
Yeah, and that's a great question about the incentive for R&D at the first instance for unmet health needs or for needs that may pose future risks. So antibiotics is a great example. No single country can provide the stimulus for R&D investments globally. And let's be clear, if Canada brought its spending on medicines down by $18 billion, like we went the route of New Zealand, it would not change the global incentive for R&D because we represent less than 2% of the world market. Even the United States, which is a major country in terms of pharmaceutical spending, is still a minority player in the global market. So no one country can affect the R&D incentives. And that's why, and I was part of the consultative expert working group on pharmaceutical research and financing coordination at the WHO, we recommended boldly, maybe foolishly, a binding treaty at the WHO on R&D investment. Because we basically say you got to decouple, delink the investment from the pricing and reimbursement. And that is the way we think you reshape incentives for R&D globally.
So it is 10 o'clock, so we'll have to cut off the questions in here now, but that's the perfect segue to mention that we have coffee for the first time. Another great change for SPPH rounds. There is coffee outside, so we encourage you to caffeinate and chat to Steve any questions that you didn't have the chance to ask in here. Talk to him out in the atrium. Thank you all for coming, and see you on October 23rd.